Hi everybody, welcome to my health topic presentation, Vaginitis. My name is Orchid Macias and I'm from Bremen University. What is vaginitis? Vaginitis is an inflammation of the vagina. Usually it's seen when you have a patient come in and they complain of vaginal odor, itch, burning, or pain. Just on a caution side, don't be confused with vaginosis, which is different than vaginitis, but they're very similar. But vaginosis still has the itch, the odor, the pain, and the burning, but it does not have the inflammation. How do women get vaginitis? Vaginitis is basically any change of the normal vaginal flora. So it could be from bacterial vaginosis, trichomonas, you got vulvovaginal candiditis, which normally is called yeast infection. It could also be in age, found in post-menopausal women. Sometimes they have vaginal atrophy, which causes a change in the normal vaginal flora. Sometimes foreign bodies, if they get left in there, also changes the vaginal flora. And other diseases as well, including psoriasis, allergic dermatitis, or lichen sclerosis. So a little bit about the etiology of vaginitis. The dominant lactobacilli that is inside the vaginal canal, they create like a acidic environment for the vaginal pH. And vaginitis usually occurs when these lactobacilli, the hydrogen peroxide dominant lactobacilli, get overwhelmed with gram-negative organisms or anaerobes. Such organisms include the ones that cause yeast infection, which is called Candida albicans. They cause about 80% of the yeast infections that you see. The literature suggests that the organism invades the vaginal canal, usually from the anal area. Another organism that you might see is Trichomonas vaginalis, which is a flagellate protozoan that is usually transferred from sex or intercourse. So it's considered a STD. Now, risk factors for vaginitis. So as I mentioned before with the Trichomonas infection, so that one's, because it's an STD, sexual activity is a risk factor for getting vaginitis. This could be including multiple partners, women having sex with other women, or having sex without condoms, smoking as well, vaginal douching, and I'll tell you a little bit more about vaginal douching later on. There was an interesting article that I found on that. Presence of sexually transmitted diseases might cause vaginitis as well. Yeast infections. The risk factors for yeast infections includes diabetes, sugary diets, broad-spectrum antibiotics, and when you're also immunosuppressed. Altered levels of estrogen, so this one kind of goes hand in hand with the age and the postmenopausal. Sometimes you might see this in women coming right into puberty because their levels of estrogen are also kind of being altered. So you might see some yeast infection or some vaginitis going on there. Sometimes when women wear tight-fitting clothes or when they have poor hygienic practices, you might see vaginitis as well. So when you get a patient that comes into the clinic, their chief complaint usually is vaginal irritation. You got the itch, maybe you have burning with peeing, or you might have a burning sensation, or just the plain old pain. Sometimes they might have a fishy odor, and usually that's a telltale sign of bacterial vaginitis. They might have the abnormal discharge consistency, might be kind of thin or thick, and maybe that cottage cheese-like kind of sticky substance. You also might see a change in the color as well, so you might see white, yellow, or green. And some women, having postcoital sex, after having sex, they might have some bleeding, so that one's considered postcoital bleeding. When they come in, make sure you take a good history from them. So you want to clarify the symptoms, like how and when did it start. You also want to do the generalized subjective and objective portion of your SOAP note. So you also want to ask them find out their age, past medical history, surgical history, social history, and so forth. Some more in-depth questions that you might think of might be, how often does it occur? If it occurs more than 4 times a year, it's considered recurrent vaginitis. And also, if they've had any previous treatments like antibiotics, antifungals, or vaginal douching, and these things might clue you in onto how they got their vaginitis. So on the physical exam, when you actually go in and do a pelvic exam, you might notice different visualizations. So first you might see a thin, watery, foamy discharge. It might have a very strong odor, kind of fishy odor, but you might not see an inflamed vaginal epithelium. So it might not be like angry red or anything like that. And that one's usually indicative of bacterial vaginosis. The other one is sometimes you might see some swelling or erythema. You might see some excoriations, some scrapes or some fissures, or some cracks or some bleeding. You might also notice some cottage cheese discharge that does not have an odor. This one's very classic of yeast infection. And for trichomonas, you might see that a greenish discharge with a fishy odor, and you might see this strawberry, quote-unquote, strawberry cervix, and that's your, I have a picture off to the right if that you can see. It's very typical of trichomonas. Now some more diagnostic testing. So when you actually look at it, you might have a pH that's greater than 4.5 because normal vaginal flora is 4.5. You might do like a positive quote-unquote whiff test, but basically you're just smelling it, and if you smell that fishy odor, it's considered positive. You might also do microscopic slides. So let's say if you get a sample of the discharge and you put it on a slide, maybe you could put one with KOH solution and then another slide with saline solution. Now the KOH kind of destroys some of the vaginal cells, and so it kind of leaves behind the bacteria cells, so that way you can see it more easily or it's more noticeable. So when you look under the microscope, you might see clue cells, blastophores, pseudophae, you might see the trichomonads cells, and if you notice the clue cells, they kind of like little dots is what you'll see, and they kind of encompass the normal vaginal cells or the epithelial cells, and so you'll see those. They look like little black dots. Sometimes they're like little rods that you might see. You might see in the yeast slide or the yeast picture in the middle. You can start seeing the lines that are growing, and those are the yeast buds, and they're actually the little circle ones are yeast buds, and the long ones are the lactobacilli that kind of or the pseudophae that kind of starts to grow and multiply, and it kind of looks like branches when you look underneath the microscope. And then the trichomonas, when you look at that one, they're kind of like circular in form. They might have like a little tail that I've noticed as well. For the diagnosing of bacterial vaginitis, again, like I said earlier, you might notice that thin, watery discharge. That's a very strong, fishy odor. It's very painful, kind of itchy. You won't see any inflammation with the actual like vaginal wall. You'll see the clue cells. And a gram stain is considered the gold standard for diagnosis of bacterial vaginitis, and that's from the CDC guidelines. And for treatment for bacterial vaginitis, you got metronidazole, 500 milligrams PO BID for 7 days, and so you'll get 14 pills. The other one is the gel form, same medication. It's just that you insert it into the vagina, and you just squeeze on the applicator, and it delivers the gel, and you use that once daily for 5 days. The other one is clindamycin, and kind of the same idea. You insert into like the applicator, and then when you squeeze it, the applicator will kind of deliver it into the vaginal canal, and you use that as well for 5 days. Any type of recurrent infections that you've noticed or the patient returns back, just repeat the treatment. Usually 1 dose takes care of it, and if not, then 2 doses definitely will take care of it. I have rarely seen 3 doses, but every now and then you might have a third dose, which you might want to consider a different kind of medication by that time. Now, yeast infections, the candidus of vulva and vagina, the other word for this is yeast infection. You get that thick white cottage cheese type. You might have some itch, some burning with urination. There won't be any of that fishy odor that I've been talking about with bacterial vaginitis, but you'll see that thick cottage cheese-like um, discharge. You'll see the cervix and the vaginal vault kind of inflamed. You'll see the blastospores or the pseudophae on the slides as well. For treatment, you use fluconazole, and that's a one-time dose, and it's PO. You take it by mouth. The other one is the topical or vaginal suppository of the antifungal regimen, kind of like nystatin or miconazole creams, and you can use that between 3 to 7 days. Any type of recurrent infections, usually you use repeat treatments. Like I said earlier, you might sometimes if you see them come in multiple times, you might want to think about different kinds of treatments for them. The next one is trichomonas. This one you'll see the green purulent discharge. It's a very fishy smelling discharge. You might see that post-coital bleeding, the post-coital bleeding. They might have some little spotting as well. You'll see the strawberry cervix that I showed you earlier, and you might see the motile trichomonads on your slide. The CDC 2015 guidelines tell you that you should use metronidazole or the tinidazole, 2 grams PO for 1 dose. You don't have to take. Usually it goes away with the single dose. Sometimes you might need to change to the metronidazole, the 500 milligrams PO BID for 7 days. So that'll be 14 doses. And it's best that you guys, when I say you guys, I'm talking about both the male and the female partner, they abstain from sex until both partners are treated or asymptomatic. You don't want to be passing it on to each other back and forth like that, playing tennis with the trichomonas. So you want to make sure that both of them are clear before they start having sex again. Any type of follow-up, usually they don't come back unless the symptoms reappear or unless they're still present. The best recommendation is to stay away from any type of sexual relations until all symptoms have disappeared or resolved. And if they persist for like 2 months, you might want to consider doing a repeat pelvic exam in this time of culture to really find out what the bacteria organisms or fungus are sensitive to. Some general measures that you would recommend for a patient: use condoms, so that way it creates that barrier between both you guys, but you still have fun. Avoid tight-fitting clothes. The tight-fitting clothes doesn't allow for a lot of air movement or breathement, and it kind of keeps everything tight, so it doesn't allow for the natural flow for things for the discharge to come out. So it kind of like keeps it all in. If a patient is asymptomatic or pregnant, you don't normally treat the bacterial vaginosis, and if you do, be very cautious about what you choose. Avoid alcohol or sugary diets. They interfere with the medication. I know beer has more yeast in it, so introducing more yeast into your body while you're fighting a yeast infection doesn't always work out very well. No oral azoles for pregnant women. Now, probiotics for bacterial vaginosis has shown inconclusive evidence as a preventive strategy, and this is part of a 5-minute clinic consult book that I found. So you could probably tell people they can do it, but it doesn't really show much evidence. So they need more studies out there to show whether it's actually working or not. Women, and one of the pearls of wisdom that they had on the same textbook was that women that experience a relief of symptoms, even without a pelvic exam or a microscope, with the treatment, so even if they don't correspond with the underlying infection. So like, let's say if you give the patient, they come in for bacterial vaginosis and you give them the metronidazole cream, they will probably experience a relief of symptoms. Or same thing if you give them the clindamycin, it might go away. anyways. Um, I follow a doctor that's been doing this for a long time, and he doesn't like to do pelvic exams, although he knows how to do everything. He just doesn't like to because he normally sees them. He thinks that he's putting them through torture, or I guess he calls it torture. When when you diagnose, when you treat them, anyways, it goes away, and not very often they come back. Um, so the gynecologist and obstetric American College, they got some more information about vaginitis as well. If you want to look up more. Now, I read an interesting article on douching, because I was wondering about that, if that's a nice go-to for a non-pharmacological way of taking care of a patient with vaginitis. And I found that it's actually controversial. And a lot of the recommendations say to use it sparingly. And that's because uh, it alters the pH, and or it removes the normal vaginal flora, allowing for different pathogens to grow. And therefore, if a lot of women do it routinely, due to good hydrate, try to keep up with good hygiene, it might actually cause more harm than good. So it might cause things like pelvic inflammatory disease, bacterial vaginitis, and there was one study that showed that it had an increase use of douching on a routine basis has an increased risk of cervical cancer as well. Different douching mechanisms out there, fluids out there include hydrogen peroxide, plain water, you got your vinegar-based ones. Some of them have proven and iodine in it, and then there are some that are commercially prepared. Uh, just to keep in mind, the lactobacilli that I keep talking about, they produce hydrogen peroxide, and what that does is it helps keep the pH in the vagina cavity in the vault low. It's of below 4.5. It also blocks pathogen adhesion, so that way the bacteria can't just stick to the wall and hang out there and start to grow. And it also stimulates the mucosal immunity, so it helps the body, start to fight off the bacteria that's there. But I keep saying bacteria, but it could be any type of pathogen. It could be yeast infection, bacteria, what have you. The other one is some people use it as a postcoital douching to help reduce the semen exposure and HIV transmission. So that some studies show that that does help. And then it seems to be a consensus amongst experts that douching is to be avoided amongst pregnant women. And here are my references. Majority of my references came from the 5-minute handbook, the 5-minute clinical consult of vaginitis. I got some information from the CDC website for sexually transmitted disease, and then the vaginal douching evidence for risk and benefits for women. That's the one that has all the douching information. Now, I appreciate you guys listening to my vaginitis slides and presentation. I hope you have a great summer and a good day, and until next time. Thanks, bye.